transverse plane, horizontal plane, yep. Alrighty, well, we just talked about protraction and retraction with the jaw, so we're good on that one. Horizontal add and abduction. This occurs at the shoulder, for example, or at the hip. And what combination of movements would that include? Let's talk about the shoulder. So if I were to horizontally adduct my shoulder, what combination of movements am I utilizing to do that? Shoulder flexion, adduction, yep, and maybe even a little bit of internal rotation, yep. So horizontal abduction would be the opposite, would be extension of the shoulder, abduction of the shoulder, and probably a little external rotation. Cool. In what plane does pronation and supination occur? Pronation and supination is rotation. Rotation occurs in the horizontal plane or transverse plane. Sorry, I should have specified of the forearm. If we're talking about the ankle,
I started doing.
if we're talking about the ankle, what movements? Let's do a supination first. Open chain supination of the ankle. What movements are we talking about? Not planes. What movements?
Oh, inversion. Wait.
Inversion.
Yeah, inversion.
Adduction and
there's three.
supination.
Plantar.
It is plantar flexion. Yep. Supination is plantar flexion, horizontal adduction, and inversion. Ankle pronation would be the opposite. Dorsiflexion, eversion, abduction. Cool. Oh man, that takes us back, doesn't it?
Recall.
Recall is right. Dorsiflexion and plantar flexion occur in what plane? What did you say, Alondra? I didn't hear you. Yeah, say it with confidence. Sagittal plane. Say it loud, say it proud. What about radial and ulnar deviation? What plane? Frontal plane. Yep. Nailed it. Inversion and eversion of the ankle. What plane?
This one was the confusing position. Horizontal. No.
Wait a minute.
It's in the front of the plane.
What plane?
Frontal.
Uh-huh. There you go. Edward can be a king. During an open chain movement, which joint partner is moving, proximal or distal?
Open chain.
Open kinetic chain, which joint partner is moving? The proximal joint partner or the distal joint partner?
Distal.
Distal. Excellent. The reverse is true for closed chain. Wonderful. Alrighty. If a concave joint partner moves against a fixed convex partner, will the roll and the glide be in the same direction or in opposite directions?
Same.
Very good. So the opposite is true for convex on concave. Good. And, ooh, lever arms. Let's review some lever arms. Can anybody give me an example of a first class lever system in the body?
First class.
Yeah, it's the head on C1. That is a first class lever system. The axis of rotation is centered between the internal lever arm, which is our muscles, and the external lever arm, which is gravity, or any resistance that's applied to the body. So again, axis of rotation is going to be through the vertebral body. The cranial extensors are located posteriorly, and most of the mass of the skull is anteriorly. So when gravity pushes down, it's going to want to make us look down. So our cervical extensors, located behind the axis of rotation, will counteract that, so we don't look down as we go through life. Class 1 lever system, don't look down. Okay, class 2 lever system. Anybody have an example of that?
The calf.
Say it again, Joel.
Heel raises.
Heel raises, yes, absolutely. So as I rise up onto my toes, specifically I'm doing extension at what joint? onto my tiptoes. The metatarsal phalangeal joint is extending, is it not? So as I rise up onto my phalanges, extending at my metatarsal phalangeal joints, that's the axis of rotation. The closest lever arm to that axis of rotation is going to be the internal lever arm, i.e. the weight of my body as being pushed down by gravity, and the external lever arm of gravity pushing down on my body weight is located closer to the axis of rotation compared to the internal lever arm, i.e. my muscles, i.e. my plantar flexors, my gastrocs, my soleus, my tibialis posterior, and so on. Those are located further away. Whichever force has the longer lever arm has the better mechanical advantage for being able to counteract the other force. So in a class 2 lever system, you have both forces acting about one side of the axis of rotation. The muscles have the longer lever arm compared to the resistance, which is body weight as influenced by gravity. We all kind of remember that? Cool. So class 3, who could give me an example of a class 3 lever system? We're all doing it. Elbow flexion, that's right. And by the way, which elbow flexor has the best mechanical advantage based on its lever arm? Say it with confidence. No, that has the largest cross-sectional area, so it can produce the largest amount of force based on its size. But who has the best lever arm? Who has the best mechanical advantage? Brachioradialis. Yep. Its lever goes all the way down towards the styloid process of the radius. That's really far away from the axis of rotation compared to our other elbow flexors. So it has excellent mechanical advantage. Nice. Nicely done. All right. That's chapter 1. We're feeling good? Cool. Let's keep it rolling. Chapter 2. Let's see what I can ask you about here. Classification of joints. I don't think I have too many of those types of questions. I might have a couple. Let's start with synarthrosis. Think sutures of the skull. These are joints that have pretty much no movement. Very, very stable synarthrosis joints. Compared to amphiarthrosis joints, this was a quiz question back in week 2. Those are my intervertebral disc joints, or my interbody joints. They have more movement, but still not a huge amount of movement. Its primary function is more shock absorption. And then pretty much all the rest of the joints are synovial joints, or diarthrosis joints. And those are characterized by the presence of synovial fluid, articular cartilage, articular capsule, capsular ligament, blood supply, and nerve supply. So if I had, let me put this in a more test-like question. If I had a patient who came in with osteoarthritis of the knee, and the patient said, man, my pain is deep inside, and boy, it really hurts. What part of the joint do you think is causing the patient's pain? Is it the synovial fluid? If it's RA, maybe, but this is OA. This is osteoarthritis. What about articular cartilage? Oh, Danila's nodding his head. Yes. What do we think? Articular cartilage could definitely be causing somebody's pain if they have osteoarthritis. What about joint capsule? Probably not.
Oh no.
Probably not. The joint capsule might be tight, but that's not what's causing the pain. Osteoarthritis is defined as wear and tear of the articular cartilage. That's what's causing the pain. It's that lining that coats the end of the bone is wearing away, exposing raw nerve endings in the deeper parts of the bone, so that whenever the bone is compressed, it sends the patient a nice zing. And while physical therapy can't make cartilage grow back, we can certainly help to decompress the joint and make sure that it is nice and lubricated, moving properly, because any sort of stiffness around the joint will contribute to those compressive forces for sure. So So if you see the word osteoarthritis, put articular cartilage in your head, because that's what's causing the pain. That's what's worn down. Alrighty. Let's see here. What kind of joint is the humeral ulnar joint of the elbow? Hinge joint, yep. What about the hip joint? What kind of joint is that?
Ball and
Ball
socket.
and socket, yep. How many degrees of freedom does that have? 3 degrees of freedom. Compared to our pivot joint, how many degrees of freedom is that? Degrees of freedom, 1. It can only move in one plane. It can only do flexion and extension, the sagittal plane, and that's it. Degrees of freedom is named based on how many planes of motion are available, not how many motions total, right? Because then we would have flexion and extension. That's still 1 degree of freedom. All right, what about a saddle joint? What's an example of a saddle joint? Be specific about the thumb. There are lots of joints of the thumb. Which joint is the saddle joint? CMC. Yep, it's the carpal metacarpal joint. And also the sternoclavicular joint. Yep, well done. Those allow for how many degrees of freedom?
2.
At least 2. Yep, and the concave and convexity changes depending on which plane we're in. Oh, here's a question you have all seen before. What kind of joint is the tibiofemoral joint? Condyloid. Say it loud, say it proud. It is a condyloid joint. How many degrees of freedom are we talking about at the knee? 2.
2.
We got flexion and extension. What else do we got?
Slight rotation.
Rotation. And rotation occurs in what plane? Transverse plane. Nicely done. You guys are awesome. Well done. Okay, let's see. I think that's all I have to say about chapter 2. Let's move on to chapter 3. Chapter 3, the structure and function of skeletal muscle, the movers of our body. How would you define a concentric muscle contraction? What happens to a muscle when you activate it concentrically? It shortens. So, if I were to ask you to identify the concentric component of a heel raise exercise, where is the muscle working concentrically that is doing this motion?
On the up motion.
On the up, yep. What happens when the heels go back down?
Eccentric.
Eccentric, yep, whereby the muscle is lengthening. It's still the same muscle working. And by the way, what muscles plantar flex the ankle?
Gastrosoleus.
Say it loud, say it proud. And we got gastrocnemius, what else?
Soleus.
Soleus, what
Or
else?
soleus.
Tibialis posterior.
Yeah.
Those are all innervated by what nerve?
Tibialis.
The tibial nerve.
Tibial nerve. Yeah.
Nailed it. Good job, guys. All right, so we talked about concentric muscle contractions, eccentric muscle contractions. So then what's an isometric contraction?
And it's not actively moving.
It's
Like the
generating force,
force.
but is not changing length,
Oh, okay.
right? So the external torque and the internal torque are equal. Excellent. Nicely done. Alrighty. Origins and insertions, agonist muscles and antagonist muscles. That's all pretty straightforward. Talked about synergists today, so we're good with that definition. I'm not going to ask you any detailed questions about how muscles contract, but I might throw in a length-related question and muscles' ability to generate force. So let's do an example. Let's talk about a two-joint muscle of the body. Let's talk about the hamstrings. Let's talk about the true hamstrings that attach on the ischial tuberosity and cross the knee onto one of the tibial condyles. I wore my book socks today because I knew we'd be studying. How would you describe this position of my right leg relative concerning the position of that hamstring muscle? What's happening to my hamstring right now? It's being stretched, right? It's in a position of full passive insufficiency because it's fully flexed. Well, actually now it's fully flexed, but it's fully flexed at the hip and it's the knee is fully extended. Therefore, it is being stretched across all the joints that it crosses as much as humanly possible, and we call that passive insufficiency. Why am I not able to generate a lot of force in this position compared to, say, this position? Why is it easier for me to activate my hamstrings here compared to here? What changed? The length changed. And what does that physiologically mean when we look at how a muscle contracts? What did I do to those actin and myosin binding sites? Shorten them?
Lengthen them.
In the passively insufficient position, I stretch them apart so they can't reach each other as effectively, which means they can't generate a crazy strong contraction compared to if the muscle were in a mid-range position. Now I've aligned the actin and myosin binding sites a lot closer together so they can contract and generate a forceful contraction. Now let's say I'm in this position, still talking about my hamstrings. Can I get a good strong contraction of my hamstrings here? No, why is that? What's the position that I put my hamstrings in? Active insufficiency, right? I have maximally shortened them as much as I possibly can. What does that do to the actin and myosin binding sites? They've completely overlapped and have nowhere else to go. They're already in a shortened position, so I can't shorten that muscle down any further. Nicely done, guys. Excellent, excellent. Okay, what else from this chapter is important? Length tension relationships are always a good one. I think we've got chapter 3 pretty good.
Can I ask a question?
Yeah, absolutely.
Can we go over the overload principle?
Ooh, that's a good one. Let me pull that one back up. Alrighty. So the overload principle is, so let's say we are trying to strengthen a muscle. And we're trying to figure out how much resistance to apply to that muscle in order to meet our goal. The overload principle basically says we have to apply a sufficient level of resistance in order to stimulate hypertrophy. So for example, let's say my biceps was really weak and I gave my patient a very light object, like a pound, and had them do the exercise. And then I asked them, how challenging is that for you? And the patient said, this is pretty easy. I feel like I could do this all day long, no problem. It's a 6 on the Borg scale, right? It's the lightest, easiest exercise ever, absolutely zero problem. Is that sufficient resistance to generate hypertrophic changes in the muscle for the goal of strengthening? No. So that's what the overload principle says, is I gotta challenge the muscle sufficiently or I'm not going to be able to meet that therapeutic goal. Now that being said, same exercise, what if my goal was to train this muscle for endurance activities? And I told the patient, I want you to do this 50 times. Would that be an appropriate recommendation for meeting that goal of endurance training? Absolutely. Yes. Absolutely it would. So you always have to match your exercise prescription, including intensity, with the goal that you have for that target tissue. Good question, Alondra. Anybody else have any questions from chapters 1 through 3? Kind of our introductory chapters. All right, let's dive back into the knee. Let's see here. Oh, no. Chapter 4 was the shoulder. The knee was chapter 9?
Chapter 10.
Yeah, you're right, chapter 10. All right, here we go, back at it again. Let's see. Let's just start with the anatomy. Name as many muscles as you can that extend the knee. Go. Say it loud, say it proud, I can't hear
Rectus
you.
femoris.
Rectus femoris. What other muscles extend the knee?
Vastus medialis.
Vastus medialis, including its oblique fibers at the distal part of the femur. What else?
Vastus lateralis.
Vastus lateralis. What else? Close. Vastus intermedius. Mhm. All right. So the quadricep muscles. What are they all innervated by?
Femoral.
The femoral nerve.
Mhm.
Absolutely. Ding, 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 ding. So, are there any other muscles that help to extend the knee? I don't think so.
Sometimes. Doesn't on the side, what's it called? TFL? Sometimes.
TFL's all
It's
the
like a-
way up
Or,
here. And it does attach into the IT band, which does go
IT
down to
band.
the lateral aspect of the knee. It doesn't have a super strong ability to extend the knee.
I think it is a secondary. Like when,
Where's our trail guides? There was a copy of it laying around somewhere, but I don't think trail guides listed as a knee extensor. Let's find out. Muscle testing, joint range of motion, physical agents. This one? No, this is just a workbook. Ooh, this is fun.
let me see if we can go back to the slides.
Alright, I'll look up another source.
How about the cards here?
Oh, there you go.
What are we looking for?
Tensor fascia lata. Yeah, I think on my notes, I just had that it can help to provide stability to the knee and maybe some rotation at the knee. But I don't think it's a strong flexor or extensor per se.
Maybe I'm thinking of the IT. Maybe I don't
Well,
know.
the IT band is not contractile
No.
tissue, right?
True.
It's just a really strong lever. Alright, I'm going
No,
over these.
in the notes it doesn't say it. In the notes it doesn't say that it is. But I
Yeah,
thought I
that's-
saw something like when like those muscles aren't working, then it
TFL.
kicks in.
TFL flex the hip, medially rotate an abduct.
Yeah, I
Oh,
think I have in
medium.
my notes too that it's just a stabilizer. It's not, it doesn't actually provide any significant torque at the knee.
Okay.
Alright, so we basically just have the quads, rectus femoris, vastus intermedius, vastus lateralis, and vastus medius. Okay, what about muscles that flex the knee? How many can you name?
Biceps femoris, long and short head.
Yep, biceps femoris, long and short head. What else?
Semi-tendi,
Semitendinosus, semimembranosus, good. What else?
Gastrocnemius.
Gastrocnemius, excellent. Yep. What else?
Was it? I forgot.
Popliteus, absolutely.
I did say
Yes,
correctly.
excellent. Anything else?
Plantaris. No.
If plantaris is present in some people, yep, plantaris can flex the knee. Good job.
What's the other one?
Sartorius, yes.
Mhm.
Sartorius absolutely does flex the knee. What else?
Gracilis.
Gracilis does as well. Yep, say grace before T.
Mhm.
Those are the three muscles that insert onto the pes serine over the tibial, over the medial side of the tibial plateau, and therefore can flex the knee. I think you guys got them all. Nice work. Woohoo! All right. We're just doing a review from the top. We're going all the way back to term 1 right now. Did you need something? Lunch. Oh, let's talk about lunch.
I'm down for sushi. we already got two
Got lots
sushi
of
right
votes for
here.
sushi.
Trying to be unbiased.
Where is
We
the
already got two
lunch?
sushi
It's
right
like
here.
literally right across the street on this side.
Unless y'all want to try the Indian pizza.
I'm okay. I'm okay with anything.
Alright, by show of hands, raise your hand if you want sushi for lunch. 1, 2,
Raise it high. Don't be-
Everybody, everybody's saying it's
Oh,
crazy.
We got it, we got it.
it's unanimous.
Go to ramen.
Alright.
Give us another option.
Well, you could have said ramen.
Yeah, we could do other options if we want to revote, but I'll need suggestions.
Taco Bell.
No,
I knew it!
absolutely not.
We talked about this yesterday.
I'm offended by that.
You know what, we're not going. Should we go now?
No, we're not
Take
taking
a
you.
All 10 of us are going.
All of Covert 13 except Danila.
Oh, boy.
I also wanted to give you these before I.
Oh,
you know what?
Well,
You wanna
do
just
have
slide
anything
it
you want?
Yeah, you know what, I got
Want
a
to try
couple of
different?
emails to print, cause I'm gonna
Do you
put
wanna
the
do-
emails,
Do you want to do the Indian
associated
pizza?
with
We have you
this
one to
one.
create.
Okay, and then I'll slide them under, and then just come and get me when you're ready.
Sounds
I'm
good.
not accurate.
That's not
Sorry.
for this.
Alright, so we covered all the muscles,
had pizza.
flexion and extension of the knee. And again, if we look at the line of pull relative to the longitudinal axis of rotation, we can isolate muscles that rotate the tibia, but it's not a functional movement that we test in clinic. We don't do necessarily manual muscle tests for knee rotation. It's just something that occurs. So speaking of functional knee rotation, let's talk about the screw home mechanism.
Yes, please.
Alright, before we dive into that, let's just get our bearings with convex and concave, right? Okay, so here's my knee. Which joint partner is convex?
It would be, yeah.
Say it loud, say it proud. The distal humerus, the humeral condyles, medial and lateral, those are convex. What's concave? The tibial plateaus, medial and lateral, those are also both concave. Does the fibula articulate here the knee?
It's the femur. You kept saying femur, it's the femur.
Oh my god.
I was like, wait, where are we talking
It
about?
happens, I swear.
Femur!
It's not the
Femur
first
with
and it's
confidence.
not the last. It's not the first
Yeah.
time it's
And I
happened,
was
it's
like,
not the
I was
last.
hella confused.
Okay.
I was like trying to
Femur with
The
confidence.
femur, the femoral condyles, the medial and lateral femoral condyles are convex, the tibial plateaus, medial and lateral, are concave. Is the fibula part of this equation? No, it is not. Is the patella part of this equation?
Yeah.
It's a separate joint.
No, just kidding.
The patellofemoral joint is separate, so don't involve the kneecap with movements at the tibiofemoral joint. We're gonna break these joints down one at a time.
Okay.
Okay, so during open chain knee extension, what's moving?
Tibia.
The tibia. And we just said the tibial plateau is a concave surface. So when I extend the knee, what's the direction of the glide?
Posterior.
When I extend the knee, what's the direction of the glide? Anterior. Anterior roll, anterior glide. Concave on convex. The movement is the same. We all there?
Yeah, I'm visualizing.
Closed chain knee extension. What's moving?
The femur.
The femur. The convex femoral condyles are rolling which direction to extend the knee? Anterior. The roll is always the same. With extension of the knee, the roll will always be anterior no matter what's moving. But now that it's a convex on concave movement, what's the direction of the glide?
Posterior.
Yes, the femoral condyles will glide posteriorly to extend the knee in a closed chain position. Knee flexion, open chain, what's moving? The tibia. What's the direction of the glide?
Posterior.
Posterior.
Closed chain, knee flexion, what's moving?
The
The
femur.
femur. What's the direction of the glide to flex the knees in closed chain?
Anterior.
Anterior. Yes. All right, we've got our bearings straight. So now, screw home. Open chain first. As the knee approaches full extension. The tibia is rolling and gliding anteriorly. It runs out of room on the lateral side first because the articular surface of the medial femoral condyle is bigger. So it's going to stop laterally and continue to go anteriorly on the medial side, which results in a net tibial external rotation. We can all see that, right? To unlock the knee with the help of popliteus in the back. First, the medial side of the tibia is going to move. It's going to take up that extra slack, which internally rotates the tibia. Then once we have even contact with both femoral condyles, the tibial plateaus will stop rotating and will just roll and glide posteriorly. So open kinetic chain, terminal knee extension going from a flexed position to an extended position, there's a net tibial external rotation. And then to unlock the knee in open chain, there is a net internal rotation of the tibia. And then we continue to flex. We all happy with that?
Question.
Yes.
But there's no rotation coming from the femur, right? Just the
In open chain, the femur's fixed. We're only talking about the tibia. So now let's talk about the femur in closed chain. So, femoral condyles are moving. They're rolling anteriorly, gliding posteriorly as I come to that fully extended position. Again, the articular surface on the medial side is bigger than the lateral side. So as I fully straighten my knee, the lateral side is going to stop first. The medial side will still keep going. Posterior glide on the medial side only results in internal rotation of the femur in closed chain as I fully extend my knee. To unlock the knee, again, with the help of my popliteus muscle in the back, the medial side will move first. We know that the femur is going to roll posteriorly and glide anteriorly. So that anterior glide on the medial side externally rotates the femur, and then once I have even contact on both condyles, we'll continue our posterior roll anterior glide into increasing degrees of flexion. One more time?
Yes, please.
Okay, open chain. Everybody take a seat.
I'd like to
I was like, let me sit down and try.
You want to try and explain it?
try.
Go, Wissam, let's do it. Everybody give Wissam some support. Open chain, terminal knee extension. What's moving?
An extension, the tibia is moving on the femur.
Correct. What's the direction of the roll and the glide in open chain knee extension?
It's going anteriorly.
Yes, everything is going anteriorly because it's concave on convex.
Right.
If the lateral side stops short and the medial side keeps going, which way is the tibia going to rotate as a result?
External.
Yes, end range extension is accompanied with tibial external rotation. To unlock the knee in open chain, to start to flex it,
Yeah.
which way does the tibia have to rotate?
Internal.
Correct. Excellent. Wonderful. You want to try closed chain now?
Yes.
All right.
So-
Closed chain. As the femur rolls and glides to extend the knee, what are those directions? Which way is it rolling? Which way is it gliding?
To extend the knee, it is posterior.
Posterior what? Roll or glide?
Posterior glide.
Yes, it is a posterior glide. So if the medial side stops first, and if the lateral side stops first, and the medial side continues to glide posteriorly, which way is the femur going to rotate?
Interior.
Internally, yes. Then to unlock the knee, to flex the knee, now the femur is going to roll posteriorly, glide anteriorly. The medial side moves first, causing the femur to rotate which way? Ding, 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 ding. Remember when that was so hard? And we just explained it in like a matter of minutes. Yay! Oh, I'm so happy, you guys. We did it. You guys should feel so proud of yourselves. All of that made sense. compared to week 3 when it was like, what the hell?
Actually, sometimes.
What?
I'm
Can you say it again?
I know
Go down, you go down.
It's a good feeling. All right.
Same difference.
Just reverse.
What movements are possible at the patellofemoral joints? Yep, we can do inferior and superior joint mopes. Any other motions that we can do? We can also do medial and lateral. So when I start, actually this bone model is good for extension. So when the knee is fully extended, the patella is sitting up above the intercondylar groove of the femur. What happens as I flex my knee? Where does the patella go? Because it does not stay here.
It goes down.
It goes down inside that groove, and that's normal. It's supposed to track up and down. But in the clinic, sometimes we get excessive lateral tracking, and that's because VMO is not holding the knee in a medial direction, and it needs to get strengthened up. All right, I think that's all I have to say about that. Ooh, here's a good one. Let's talk about posture of the knee. Let's talk about alignment of the knee. What is the correct terminology for describing somebody who stands like this?
Valgus.
Genuvalgum. Is that because of tight muscles necessarily? Does this always mean that something's tight or weak? No. What other alignment could be causing somebody to stand like this? Milton's pointing at his hips. Are we all thinking that? That's the normal angle of inclination. So let me draw that up on the board real quick.
Why, thank you.
All right, so here's the acetabulum, and here's the femoral head. Shaft, greater trochanter, neck, greater trochanter, and shaft, and then here we'll just draw a patella to represent the knee. There we go. Okay, so what's normal angle of inclination?
Was it 15? No, 15 was
About 120, 125
I
degrees.
think you did a thing.
That angle is important to centering the knee over the tibia so that we don't knock knees or have the opposite genuvarum. So if this angle is too small, let's say this angle is only 105 degrees. Here's the center.
That's what I was thinking.
That's gonna bring the acetabulum forward, which means that in order to fix this, we have to abduct the thigh, which causes varus at the knee. So valgum at the hip causes varus at the knee. And varus at the hip causes valgus at the knee. So just remember, coxa causes genuvalgum and vice versa. Hopefully I said that right. Make sure that I did. It's been a hot minute.
We got on record.
I know, right? If I said it wrong, I owe you lunch.
Wow.
Everyone's like, hey now. No, I'll bring you donuts on test day if I said it wrong. Yeah, coxa causes genu... Hold on. Hold on. I know it's opposite, but I think I did get it mixed up. Started off on the right foot. If this angle is smaller, that means, oh, I drew the dot on the wrong side, that's why. There we go. If that angle is smaller, that changes the position of the femoral head in the acetabulum, which means I have to adduct the thigh to bring it back into the center of the socket. And if I adduct the thigh, that creates genuvalgum. That's where I got backwards. So valgum down here caused by coxa coxa vara, a smaller angle of inclination, causes valgum at the knee. Coxa valga is a larger angle, resulting in coxa.
It's time for lunch.
It's time for
It
lunch.
is time for lunch. Let's take a break and revisit this when we come back, and I can actually speak again. How about that?
Depends how much sushi you eat.